Welcome, everybody. As I said, this is the Department of Internal Medicine Grand Rounds. We are excited to be joined by Dr. Clyde Yancy on a topic called Unraveling Healthcare Disparities After COVID-19. And just to tell you a little bit about Dr. Yancy here while we get things set up, and then I want to tell you a little bit, he is the Division of Cardiology Congdon Visiting Scholar, and so we want to tell you all a little bit about the Congdon family. So Dr. Clyde Yancy is the Vice Dean of Diversity and Inclusion at Northwestern University, Feinstein School of Medicine in Chicago, Illinois. He's also the Chief of Cardiology at Feinberg School of Medicine and Associate Director of the Bloom Cardiovascular Institute at Northwestern Memorial Hospital. He holds the Magerstadt Endowed Professor of Medicine chair and an appointment as the Professor in Medical Social Sciences. Dr. Yancy's research interests are heart failure, outcome sciences, and healthcare disparities. He's extensively published with over 600 peer-reviewed publications and annual recognition as one of the most highly cited scientific authors worldwide. Dr. Yancy is deputy editor of JAMA Cardiology, and he served on various government advisory panels, including at the NIH and FDA, as well as held roles in national associations, including former president of the American Heart Association, and he has earned national recognition by ACP through his mastership designation. He's an elected member of the National Academy of Medicine and Association of American Physicians, and he's recognized as a national leader in cardiology and highly regarded as a preeminent thought leader in diversity, equity, and inclusion. Today's Grand Rounds is brought to you by the Division of Cardiology and the VCU Health Poly Heart Center. Today's Grand Rounds and funding comes from the Natalie and Jack Congdon Visiting Scholarship Program. I want to tell you a little bit about the Congdon family. In 2009, Jack Congdon established the Natalie and Jack Congdon Visiting Scholarship in Cardiology, which enables the VCU Poly Heart Center to attract a number of talented cardiologists. A little bit about Jack, and then we'll talk about Natalie. John Jack Rhodes Congdon was a student of Augusta Military Academy and a graduate of Thomas Jefferson High School, where he was the first captain of the Corps of Cadets. He later served in the United States Army as a military policeman stationed in San Antonio, Texas. After his service in the Army, Jack helped build the family trucking business of Old Dominion Freight Lines and Old Dominion Truck Leasing Company. Jack was a master mason with Tuckahoe Lodge number 347 and a noble of Acca Temple Shrine in Richmond, Virginia. He served as president of both the River Road Civic Association and Virginia Highway Users Association and a proud supporter of both the Macy Cancer Center and the Poly Heart Center. He passed away on October 13, 2013. Jack's wife of 57 years, Natalie Congdon, graduated also from Thomas Jefferson High School, where she was a sponsor of the Cadet Corps and queen of the Junior Senior and attended Hollins College. Natalie was an active member of the River Road Church, the Tuckahoe Women's Club, and the River Road Garden Club, president of the Monacan Junior Women's Club, and a chairperson of the Collegiate Village Green Fair. Natalie passed away in January 6, 2010. Jack and Natalie have 3 children, Susan, John, and Jeff, 8 grandchildren, and 5 great-grandchildren. We are fortunate and thankful for their continued sponsorship in the Division of Cardiology and Department of Medicine. I'm going to turn it over now to Dr. Yancy to talk to us about unraveling healthcare disparities after COVID-19. And we'll hope to save about 5 to 10 minutes at the end for a question and answer session. Thank you all. Appreciate it. Dr. Yancy.
Thank you, Dr. Bergman. Please confirm that you can see the title slide in full presenter view, Unraveling Healthcare Disparities After COVID-19 on your trademark. Terrific. Well, first, my apologies. It is not my norm to be anything other than prompt for scheduled activities, but I had a morning clinic for a number of patients that needed to be seen. And between my morning grand rounds with your cardiology division and now this afternoon's grand rounds, we needed to see some patients. So on the one hand, it's a wonderful attribute. I would hope you would believe that I continue to be clinically very active while we have these academic pursuits and these pursuits in the equity domain, but it's also poor form and I accept the responsibility for being late. So my apologies, time is valuable for you and I should not have made you wait. but I do want to give you the best benefit of the perspectives that I wish to share with you over the next 30 minutes to allow sufficient time for questions, because I think as we have all navigated the last year or maybe 18 months, it's important to understand what are the lessons learned. Do we just take a sigh of relief and say, at least the Alpha variant is behind us and maybe the Delta variant will be behind us, and let's hope that the new variant doesn't disrupt life again? But regardless, there are lessons learned, and if we don't want to experience what we've already suffered, we don't need to allow history to repeat itself. I want to also make deference to the largesse of the Congdon family. I understand that relatives of the Congdons may be in the audience. I made the same acknowledgement this morning, and I'll make it yet again now because I realize this is a different audience being for the Department of Medicine. But those of us that are in leadership positions and structured enterprises, academic medicine, if you will, recognize the value of this kind of philanthropy that allows us to curate speakers and content from beyond our own walls and really add to the educational experience. And so my gratitude, my thanks to the Congdon family for their sense of altruism to make something like this possible. I'm sharing with you the trademark from the Heart Failure Society of America meeting that started last Friday and concluded on Monday of this week. And I'm sharing with you the trademark of the Harvard Catalyst program, which is a part of their CTSA. I'm sharing with you those two trademarks because in both of those domains, the Catalyst program having occurred on Tuesday, in both of those domains, these kinds of conversations were deemed to be relevant. My point is that as we talk about healthcare disparities and what we've learned, and I bring forward to you this sense of unraveling that process, it is in keeping with a national discussion which I've had the privilege of enabling, informing, and understanding. And I want to be able to share that with you. It's really important to have a pause moment here. There are things over the next 25 to 30 minutes that are going to be difficult, disquieting, but absolutely necessary if we in the healthcare enterprise are to appreciate what we can do differently when we think about where we've been. I'm going to start with a viewpoint that we place in the literature in JAMA in April of 2020. This was one of the first reports to demonstrate the disproportionality of COVID-19 on Blacks and self-described African Americans. It's a fair amount of objective content in this statement, but where this statement really resonated with so many was that we endorsed the fact that it was COVID-19, and this was early in the process. This was based on data just through March of 2020. That COVID-19 had been the bellwether event that fully disclosed the extent to which healthcare disparities exist in our country. Conversations about healthcare disparities are not new. They've been going on for decades. I've been a part of these discussions easily since the year 2000. But why COVID-19? It's been because of the magnitude of the problem. I made a habit of frequently visiting those sites that aggregated data for public health purposes, the CDC, the Hopkins website. But then I found this website, the American Public Media Research Lab website. And I was drawn to this in part because of the subtitle, The Color of Coronavirus. This site uniquely aggregated public health information from every state by virtue of race and ethnicity as best as it could be ascertained, and brought this forward in summary statements, originally on an every week basis and an every 2 week basis. That exercise ceased through the end of March, through the end of February, beginning of March. But the data I'm sharing with you is in one of the last compilations of the burden of COVID-19. Think carefully about what I'm going to share with you. 1 out of every 475 Indigenous Americans is now dead due to COVID-19. Not an associated death, an attributable death due to COVID-19. 1 out of every 600 Black Americans and every 600 Pacific Islanders now dead. When you look at these numbers and then you understand the excess number of lives lost compared to what might have been expected, just attributable to COVID-19, at a time when the total was 440,000 deaths, and realizing that now was 660,000 deaths, you begin to process this disproportionality. But right now, this is by a relatively crude descriptor, race or ethnicity. But then the website did something very important. It made a pivot. And in the spring of 2021, it went from aggregating deaths to aggregating data on the uptake of the vaccine. The paradox, the difficult paradox, is that exactly in those groups where the disproportional burden of disease was experienced, we see the poor representation of vaccine uptake. I share with you that I'm just coming back from an outpatient clinic, and there were several persons self-described as Black or African American, and I was struck that most of them had not taken the vaccine. Even though they're my patients, they've heard my voice. I've had a very public presence locally and regionally advocating for vaccine use, and they've yet not done this. And so you get the sense that there is this odd disconnect between the vulnerability to the condition and the protection from the condition. That makes us begin to think more critically about what is going on here when we say that these health disparities are here. When we talk about defining a crisis point, what is going on? And I think I'm going backwards instead of forwards, my apologies. It means then that we have to recognize that if we're talking about something as a function of race or ethnicity, we should be very thoughtful about how we use this. Because when we do crude counting just based on race, we come up with statements that are amplified, statements that are used to evoke certain initiatives. But we as investigators, we as astute clinicians, need to consider in greater depth how we exactly use race in medicine. Along those lines, and in January, we placed this statement in JAMA, working alongside John Ioannidis at Stanford and Neil Poe at UCSF, to make the argument that we have to be very careful about how we use race in medical research. There's a necessity to recalibrate. We can't just report results as a function of self-report or administrative capture of race and ethnicity. We have to understand that race does not qualify in any regard as a measure of biology. And when we approximate race to the social construct, the test of that hypothesis is that race fails as a reliable predictor or surrogate marker of the social construct. Moreover, in work that we've also placed in the literature in JAMA Cardiology, working with Dr. Beth McNally, who is one of our associate editors within the JAMA network and on my faculty at Northwestern, and is a national expert in genomics, we have argued stridently that if the question is biological, meaning you inferring something attributable to African ancestry, we can measure that. If the question is about the social construct, don't just approximate race to the social construct, measure it. We can measure it with a number of indices: the social vulnerability index, the distressed communities index, the area deprivation index, simple geocoding. There is a way to capture that social aspect of life and living that creates certain vulnerabilities. And then once we've considered these issues of biology and once we've considered these issues of sociology, the residual differences that are function of race really fall into that space where we begin to talk about issues of bias. But it allows us to deconstruct the broad statements that are race associated and begin to understand some clinical science that underpins this. So let's think about that. If you accept my hypothesis so far, that we have to be thoughtful in a way that makes us go beyond just thinking about race, begin to think about the actual social environment, understanding that biology is a separate question. And that means, can we identify those communities? I've thrown out a couple of indices, but can we actually use them in a constructive way? This is how I think we can do so. I can't see the room, but I would hazard a guess that few of us have actually developed any facility using the social vulnerability index. This is represented by the aggregated assessment of 15 US Census variables with a generation of a score. The score is either close to 0 because the community has the highest resiliency and the lowest vulnerability, Are the scores close to 1 because of the highest vulnerability and the lowest resistance? So again, taking ordinary census tract data, bringing 15 of those variables together, calculating the score, and specifically trying to determine that if a community is met with some external stress of substance like COVID-19, but other things as well, thinking about the hurricane season that we're in right now, what's the vulnerability to that community? So theoretically, that is a reasonable thought process. I'm giving you this presentation from downtown Chicago, Streeterville. If you're accustomed to the topography in Chicago, you can see that small juxtaposition that's Navy Pier. So the cursor is correct, that's Streeterville. What do you think the social vulnerability index is in downtown Chicago on the campus of Northwestern University? Here as I'm seated, it's close to 0, meaning that this community has the lowest vulnerability and the highest resiliency. And that's what we've experienced over the last 12 to 18 months. But what happens if I move the cursor 10 miles south? One of the prototypical South Side neighborhoods. The score is 0.94. It's very close to 1, very close to a community with the highest vulnerability and the lowest resiliency. Well, that validates thought experiment because after all, it's looking at already collected data that were brought together, generate these scores, and you can see the gradation. But here's where it begins to change. Part of what drove that publication in April of 2020 was the realization of this disproportionality that was not only disproportionality in self-described Blacks, and the same for Latino or Latinx, but it was actually limited to just several neighborhoods. 4 zip codes, 5 neighborhoods on the south side, and 2 zip codes and 2 neighborhoods on the west side, exactly where persons of Latino origin might live and where patients of African American or Black origin might live. And so that began to raise the possibility that yes, we identify this disproportionality by race, but look at how peculiar place happened to be. We then go back and do the same exercise, this time with the social vulnerability index. The darker the color, the closer to 1 the community happens to be. And where do we see the concentration of these darker colors? On the south side and on the west side. And if we then do one more exercise, if we overlay the COVID-19 fatalities in Chicago on the map that now is representing the geocoding, the social vulnerability index, and the fatalities, we can't argue cause and effect, but the association is very strong. I would hazard a guess that this may be the first time anyone has inclined you to think not just about the race disproportionality, but about the place disproportionality, because it argues that there's something about place that must have been pertinent as we make these observations. Let me give you a hypothesis that is not unreasonable. Again, I suspect that everyone listening in has heard of the phenomenon of redlining. But other than hearing about it, do you know what it is? Coming out of World War I, as part of the New Deal, there was a recognized housing deficit in this country. In good faith, the federal government launched a corporation called a Homeowner Loan Corporation, intended to identify communities where federally backed mortgage securities could help promote housing. This corporation made an assessment of creditworthiness, and literally in those communities that were deemed least creditworthy, they received a D score, and on a map, they were outlined in red. A red line was drawn. The adjacent communities with a better credit score were in yellow. Let me share with you something that is quite illustrative. This is the map from the 1930s, demonstrating the communities in Chicago subject to redlining and yellow lining. Again, you can see the landmark of downtown Chicago and Navy Pier. You can see moving south and moving west, a predominance of red. Now, you would ordinarily believe that if someone was in a community where you could not receive a mortgage, you would move to the community where you could. But because of the burden, the heaviness of segregation in the first several decades of the 20th century in Chicago, still in a post-Reconstruction, early Jim Crow era. Black Americans, African Americans, were forced to remain in these communities that were deemed least creditworthy. And these same communities received the least amount of support for public education, for transportation, for public parks, for quality jobs. You can see where I'm going with this, because now, if we fast forward to the pandemic of COVID-19, the map I just walked you through, including the narrative about the social vulnerability index, exactly overlays with the redlining map. And so it is a hypothesis worth considering that a system, a policy established 90 years ago, erected structural disproportionalities that may in part be responsible for some of the excess mortalities seen currently. It's really remarkable to think about the policy from 90 years ago may have had a bearing on how life is experienced today. I'm sharing with you a heat map. Those of us who do outcome sciences or epidemiology are so accustomed to these heat maps. What is this heat map? Well, earlier I showed you with the American Public Media Research Lab website, the burden of mortality, and then the disproportionality in the uptake of the vaccine. This is a map showing the percent of persons fully vaccinated according to that social vulnerability index that I've already described. There are no data available from Texas because Texas didn't report. But let me share with you the scale. Once again, in pale pink on the horizontal axis is the social vulnerability index, like we have in Streeterville, close to 0. And in burnt orange, there's a social vulnerability index close to 1, akin to what we see on the South Side. When the communities with the social vulnerability index close to 0 receive vaccination, as the percent increases, the depth of blue increases. And so the sky blue color is representative of those communities that have the least amount of vulnerability and the greatest vaccine uptake. When we see the deep purple, it's those few communities that have the greatest vulnerability but have in fact received the vaccines. The map then tells an incredible story. If you look at the Northeast, the upper Midwest, the coastal areas, you see a lot of sky blue counties. There are a few pockets of purple where, despite the vulnerability, there's been really robust uptake of the vaccine. But look across a prototypical stroke belt. These data from the CDC, downloaded just in August of 2021. So they are current. You see these hues of red and orange, meaning that we have communities that are already very vulnerable and where there's been underutilization of the vaccine. Moreover, if you take a big step back and say, why are we dealing with the Delta scourge? Look at how we have experienced a disproportionality in the uptake of the vaccine that seems to be in concert with the risk of the communities to an outsized effect from COVID-19. The last thing I'll share with you is that here in Chicago, if I step outside and I get on the train and I go to Inglewood, which is the prototypical neighborhood on the South Side, for every mile, life expectancy drops by about 5 or 10 years, so that there's about a 30 year delta between life expectancy in Streeterville and life expectancy on the South Side. The name of that train is the Red Line. So I am telling you a story that can be summarized with these lessons. COVID-19 was the event that exposed the depth of health disparities in the US. I hope that I've introduced to you a reasonable argument that even though many of these disparities were originally and still are described as a function of race, the place is very important. And that if we take an index that approximates the social determinants of health, we come away with a very different set of observations. That one, those areas of vulnerability really represent where the greatest burden of disease was. And two, there may have been issues of public policy, perhaps decades old, that generated the deficits in community services and community resources that led to this vulnerability. As a consequence, then, we now see that not only for COVID-19, but also for the use of the vaccine, we still see this disproportionality that varies by race and varies by the social determinants of health. And so taken together, we now understand that there were some important lessons learned just from that event. But there was more than just COVID-19 in the last year. We clearly went through a time where there was a critical reckoning on issues of race. You remember this poetic recitation from the inauguration. I won't recite it, but I've underlined one line: we braved the belly of the beast. It wasn't just COVID-19. It was the disrupted social experiences. I'm going to take you through a number of images with no narration. I want you to simply view the images and then process how they make you feel. Image number 2. Image number 3. Image number 4. Image number 5. And in January 6, 2021. Think about how you felt. Some of you may have looked away. Some of you may have wished we hadn't seen these images again today. But there's an important point to be made. Each of us processed the information, whether we were dismissive, whether we experienced a moment of pain, whether we were disgusted, whether we were just bothered. We understand that some of us may have had emotions of sadness or despair. We may have seen violence and anarchy. Others of us may have seen evidence of civil protest, freedom of speech, the right to bear arms, social justice. The point is that we all process information according to certain neural circuits. And this critical work by Daniel Kahneman, for which a Nobel Prize was awarded, it was made evident that we either process information quickly, typically based on past life experiences, usually associated with stereotypes, or we adopt a slow pathway where we're more cognitive, more deliberate, and tend to process what we see into what we actually intuit and how we cogitate on these sort of events. That's important because it introduces a very key concept: bias. You remember early on when I shared with you the original data that was race-based, and then put the argument that we as clinicians, as investigators, as scientists, need to pause and say exactly what do we identify when we describe something as race-based. I talked briefly about looking at genetic ancestry. I talked more extensively about measuring the social construct, but then I said, if the difference persists after we do all of that, that's when we have to introduce bias. And remember that each of us has a bias. It's ubiquitous. Remember that bias is unavoidable because it reflects our individual life experiences. As you were looking at those pictures, you either consciously or subconsciously were exercising your own bias. The lens which you use to view those pictures was the expression of your biases. And in the US, consistently, when the implicit association test is deployed, everyone, regardless of their demographic, has nearly a 70% preference for European ancestry individuals, especially men. So this is a very important and telling statement. These data are from medical students at Hopkins. For 8 consecutive years, I've led the bias module for our medical school. We tested our enrolling students at their option, and we see the same thing. It really forces us now to understand that in this schema where bias is operative, sometimes the fuller expression of that implicit bias, is an overt belief that people are fundamentally different, where one group is at a higher tier, one group is at a lower tier. You can see the definition for racism. But you also see that racism is not just one experience, it is multi-dimensional. The cultural racism is self-explanatory. How are people depicted in media, etc. But the personal racism, and especially institutional racism, those things are quite different. This is a personal testimony that we put in the literature in June of 2020 to really give everyone a context of what it feels like, because we used the word almost glibly. We developed an immediate visceral response to reject it, to acknowledge it, but hardly ever do we have a narrative that tells us what it looks like and what it feels like. I'll pause for about 8 seconds so you can read this. That's a personal testimony for what racism feels like. But now I want to go to something else that again is along the lines of an academic exercise. And the reference here is the Aspen Institute. This is an uncomfortable truth. Conversations about structural racism are volatile. They politicize our community, they polarize our community. But if we take a thoughtful, scholarly approach and just look at the first sentence to identify an operative definition, we walk away with a different sense. It's a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. Let me be very clear. It says structural racism. It could also say structural sexism. It could also say structural xenophobia. It could say structural ageism. It could also target persons of the LGBTQ environment. It could target persons with certain disabilities. But the definition is operational. I'm going to go through another silent thought experiment with you. This time I want you to read this quotation from C.S. Lewis. Again, another 8 seconds. I think you can begin to see the point. If we can remove the emotion from this, if we can reflect back on the experience with COVID-19, the select neighborhoods that were involved, which are the neighborhoods where persons of certain races live, and the history of how those neighborhoods in part became disadvantaged, realizing that policy drove a lot of that, and then understanding in this very prosaic statement that people make policy. So even though we blame the policies, originally the policies were declared by people. So what's the second set of lessons learned? Remember, the first set was the heft, the disproportionality of COVID-19, the realization that place may have mattered as much as race, the awareness that certain structural barriers may be the reason for the vulnerabilities that can be measured with something like the Social Vulnerability Index. And now we've taken you through a thought experiment for the concomitant other crisis we endured over the last 18 months, and we're still navigating. That is the social disruption. So what are those lessons? This is so evident, and it is a reality that we can't ignore. There is a deep social divide in this country driven by race, and regardless of our political point of view, our volitional experience, it impedes our aspirations. That is a truism. Real critical question, particularly when we think about the most recent United States Census variables, the world is changing, and the demographics have changed strikingly in the last decade. So the really important question becomes, if the world is changing as it's been quantitatively and objectively described, and if the world as we know it is working with this deep divide, a divide that impedes our opportunity to be our best vision of our life and living, the question becomes, will we change? Maybe an existential question, but one that we can put in play. So in the last several minutes, what are the solutions? And this is where we begin to have a more overt discussion about diversity, equity, and inclusion. I'm particularly drawn to this statement from H. Holden Thorpe, the editor of Science magazine. Look at his commentary, and then science and scientists finally need to listen to and make space for people of color to lead laboratories that publish great science and produce influential scientists. And this was juxtaposed with a compelling statement from a minority woman, accomplished scientist in her own right, who simply said this: how much creativity are we leaving on the floor? There is so much substance here. This takes us beyond diversity as a head count and begins to introduce the notion that when we make space for, when we listen to people of color, the possibility exists that we can enrich the science that we're producing. And we have to think very carefully, not only about whether or not we will change, but if we don't change, how much creativity are we leaving on the table? Very important issues to consider. So a lot of people in C-suite want to approximate all of this to a head count. If we just change the numbers, we will have been responsive. Is that the solution? Let me be very clear. It is not about representativeness. It is about excellence, growth, and prosperity. And you might think that that's rhetoric, but I would argue that it's not, because there are important lessons that corporate America has given us. Look at this statement from the Harvard Business Review. When you create inclusive work environments, think about your hospital, think about your medical school, where diverse voices are welcome and engaged. Those environments are nearly twice as likely to achieve value-driving insights. What about from Deloitte and Touche? Again, organizations like hospitals and medical schools and clinics with inclusive cultures, 2 times as likely to meet or exceed financial targets, 3 times as likely to be high performing, 6 times more likely to be innovative and agile. Which of us as leaders of a healthcare enterprise wouldn't want to see a community that was high performing and agile? And what about this one from Forbes? If you measure the quality of the decisions that groups of people make that drive enterprises, like a healthcare enterprise, when the decision makers are homogeneous, in this case, all male, all white, 58% of the time post hoc, those decisions were deemed to be favorable. That's better than a coin flip. Some would say that's success. But look at what happens when you add gender diversity. When women come into the room, 73% of the time, the decisions are better. What about age and gender diversity? Both the early career and the more seasoned individual with the wisdom. 80% of the time, those decisions are more appropriate. And then if it's age and gender and geography and race and ethnicity, it's 87% of the time. What leader wouldn't want to see the quality of their business decisions go from being 58% right to 87% right? This is why we can be so explicit, make the argument that diversity is not about a head count. It's about an opportunity to introduce diversity of thought, creativity, and have a more successful enterprise. So what are the lessons learned when we think about this third part of the discussion? The first part was about COVID-19. I've highlighted those lessons learned. The second part was very tough. It was about the disruptive social experience we've been through and the realization that we have a divide in this country. But the third part, is this a solution? Is diversity a solution? Diversity empowers, it doesn't impede. We shouldn't fear this. Diversity enhances, it doesn't limit. Diversity includes, doesn't exclude. Again, it is not about representativeness. It is about diversity of thought, about diversity of ideation, about diversity of creativity. The last thing I'll leave with you in just a few moments is leadership the solution? I believe fervently that if we're to see the kind of change in our enterprises, now thinking uniquely about healthcare enterprises, these changes have to be articulated at the top, embraced at the top, and championed at the top. There must be a champion for this kind of fundamental change. With that in mind, then the first step is to challenge the notion. Leaders have to understand that diversity does not regress us to a mean, but it's a pathway to excellence. And leaders need to value the importance of equity and appreciate that this is the new attribute of professionalism. It's a striking exercise. If you look up the attributes of professionalism as they exist today, equity doesn't appear. I'm arguing that we should incorporate equity as a new attribute of professionalism and recognize that when we achieve equity, that is a distinguishing characteristic of exceptional leadership, and who wouldn't want to fall in that category? We should take a deep breath and exercise some courage, because this is difficult. Depoliticize racism. Talk about the quantitative, objective components. Acknowledge the reality. Very important that we don't try to change feelings or emotions. Can't do that. But we should target barriers. We shouldn't try to change the human, but we should try to change the process and target the policies previously established by others that are impeding the success of others. Remember, the greater goal is improving our enterprises, inclining towards excellence. To do that, we have to create plans. We have to hold ourselves accountable, and we have to form groups that specifically manage this real time. It can't be an afterthought. It has to be an ever-present thought. Again, this can't be an afterthought. It has to be an ever-present thought. And what about dealing with medical workforce diversity and all the challenges that are incumbent thereof? Take this commentary from Winston Churchill. Success consists of going from failure to failure. without loss of enthusiasm. If we at Northwestern, if you at Virginia Commonwealth University want to fundamentally change, be champions of health equity, you will fail. But if you don't tire and don't lose your enthusiasm, you will realize success. So here's a summary. Everything I'm trying to share with you today about lessons learned from COVID-19 and the steps we need to take. This is hard work. It truly is hard work. Expect your own DNA, your own personal constitutional challenge. As you execute on these opportunities, and I do mean they're opportunities, not tasks, be patient, be fearless. As Churchill articulated, expect to fail, but maintain your enthusiasm. Importantly, listen. If we just take the time to listen, we'll find that things will go along well. I love this African proverb that says this: be quick to listen, be slow to speak, and even slower to anger. It's a beautiful way to think about this. But also, for those of us in leadership, we have to be certain that there is a sameness throughout the leadership hierarchy. This is important at the C-suite, the next tier, the next tier, and the next tier. I'll leave you with a final quote. I've allowed time for a few comments and questions here at the end. I'll leave that up on the screen for just a few seconds. But while it's there, I want to once again thank the Cogden family and any members of the family that are present. I know that I've led a very difficult set of thoughts for everyone to consider today, but it's a necessary set of thoughts because we cannot be nihilistic about what we've experienced over the last 18 months. I tried to give you some realities here. I tried to give you some overt lessons we've learned from COVID-19 per se about the disproportionality and the root causes for that more than just race. I've tried to articulate that we can't separate the experience of COVID-19 from the social disruption that occurred. And yes, there are lessons to be learned, none more important than the fact that we have work to do. We have a big divide. But I've given you hope and said one way we can target this is by targeting diversity, not because it's a head count, but because it's a pathway to get new ideas, new voices, new concepts in the room. And that in so doing, there are many examples in the business world that says we will be a better business enterprise, and I can assure you we'll be a better human enterprise as well. Thanks very much for this opportunity.
Wow, phenomenal, Dr. Yancy. That was extraordinary. I practice in nursing home settings, and we have certainly seen inequities in care across nursing homes with COVID-19. So I really appreciate you shedding light on that. And I think it was a very thoughtful presentation. Thank you.
Thank you. I know these are difficult concepts, so I appreciate your kind words. Thank you.
No, thank you. Dr. Syme is the chair of our Department of Internal Medicine. Dr. Syme, do you have any comments or reflections from the talk? And then I think we have one or two questions we'd like to get to. You're still muted, Dr. Syme.
A lot of people would like me to stay muted, probably. No, I think, thank you very much, Dr. Yancy. That was tremendous. And I think, very near and dear to our hearts here, we serve a broad population here at VCU, and the social determinants of health are things that we think about every day. So, just incredible insight. Appreciate your efforts. And I can see there's questions popping up. So I would like to let the audience ask their questions. Thank you for sharing your expertise.
Well, thank you, Dr. Syme. You made me smile. As a leader like yourself, sometimes I think they want my mute button to stay on as long as possible. But in a very serious way, one of the advantages of having this collection of thoughts is it allows us to go beyond race, begin to think about other circumstances that affect health quality. I'm thinking about your proximity to West Virginia, to Appalachia. That is a very real concern. Those social determinants of health are as poor as they are for indigenous communities and certain inner city communities where Latinos and Blacks live. And so we can learn from this experience collectively, because the burden in Western Appalachia is just as great. The burden in the Delta, Mississippi, poor white individuals, is just as great. And so these are important concepts.
Hi, Dr. Yancy. Thank you so very much again for your excellent talk. I do have a question. Unfortunately, due to history, we unfortunately have many African Americans who do not trust medicine So as a result, and this is just one of the problems that come with this, but as a result, even though the COVID vaccine is available, there's still a lot of mistrust and a lot of our patients who do not want to take the vaccine. And in the same line, there are a lot of them who do not want to participate in studies. You just mentioned that you were in clinic and a lot of your patients have not accepted to take the vaccine. So you have definitely encountered this. How do you approach these patients? How do you get them to trust you and encourage them to participate?
It's a wonderful question, a challenging question. I'm going to give you a very pithy answer that I think is the real solution. The trusted voice. Once upon a time, the trusted voice in American medicine was the doctor. That has been so politicized and so targeted that we can't say that's it. So we need to understand who the trusted voice is. And unfortunately, we've allowed the trusted voice to become a series of uninformed voices and or a very difficult history that's passed on from generation to generation. And so the way in which I think we can do this, particularly in the Black community, is community engagement. That's why we started a program here at Northwestern called Clergy and Clinician. So periodically, I am on television with an area minister, and we use plain spoken language. I am at the hip with the minister, and we develop these narratives and promulgate these narratives in targeted communities. But that's not the only trusted alliance. In community health clinics, in federally qualified health clinics, we seek these trusted voices, the people who are the nose in their communities, who really carry some substance, who carry some weight. Some of them may be inarticulate, but they're very sincere. And I think we have to become accustomed now to going outside of our realm. And one word about the clinical trials, I've been deeply involved in this with the FDA. I'm leading a number of NIH trials as we speak, looking for new therapies on COVID-19. Our success in recruiting a diverse population has occurred when we've gone beyond the norm. The norm has been major academic institutions, established clinical research organizations. No, we've gone to communities. We've gone to communities we've not been before. We've had different faces, different voices, bringing forward consent forms and protocols. As a consequence, we've got 30 to 40% representation of those persons that have never been in trials. So the answer to the question is find the trusted voice. If you can do that, that will begin to make some difference.
Thank you, sir.
Thank you all. We have Dr. Alan Dow. I don't know if he's still available on the line, but he had asked a question in the chat box here. I think we can tackle this one last thing before we close out our session. A challenge with this work is that we want to depoliticize race, yet one party has embraced denying the existence. How do we try to be inclusive and collaborative in this politicized to the point that there could be some racism denial? Any thoughts about how we can remain unbiased in this approach to this problem in the current situation? Any words of wisdom?
So the first word of wisdom is not what you think. You would think I would say education, but how long have we been doing that? How long have we been doing that? The real answer to this question is the solution for everything in America when we want to change a narrative: marketing. We've not tried to market our public health enterprise at all. We've not tried to go to the voices that are those trusted voices, those familiar voices, which unfortunately come from sports and entertainment. But marketing in this country is so powerful, so successful. The clothes we wear, the items we use, the way we recreate is a product of marketing, but we haven't applied that to public health. So I'm not going to minimize the problem, and if we add the politics in, then it becomes quite difficult. But that should not deter us, because that only means that the structural differences will remain. But if we use a different approach, an overt marketing approach, using social media for the good, if we can enjoin those persons that can capture the attention in the social landscape, nobody wants to listen to an old bearded bald-headed doctor say anything. But if we have someone who shows up and the image, the voice is what they are accustomed to hearing, then maybe that kind of marketing will de facto be the kind of education that we need. But we have to be tireless. We have to be persistent.
Thank you so much. On behalf of the Department of Internal Medicine, I want to thank you for taking time to join us for this hour and for your presence this morning with the Division of Cardiology and your ongoing assistance to the division. Also want to thank the Cognon family for the professorship today and the support for the talk. Dr. Syme, any closing remarks or thoughts?
No, thank you very much. Great
Thank you so much.
Patricia.
Thank you, Dr. Yancy. Thank you, Dr. Syme, everybody. Have a good day. Take care.